Alright, so this is the lecture for August 6th on Thursday. If you look under day 6 that's kind of interesting, August 6th for day 6. Anyway, your lung topography PowerPoint, it's a fairly small, short PowerPoint. I want you just to go through that yourself and become aware of the different landmarks on the chest wall. It's going to go over fissures, it's going to go over your mediastinum, your sternal area, your xiphoid, and you're going to use that as a guide to help you with your assignment that is due on the 13th there, that homework number 5, the drawing of the lungs and landmarks. When we're on campus on Monday doing the physical examination checkoff, remind me and I can send you home if you'd like with a big piece of chart paper that we have in that other classroom. The classroom there currently right now is the colder classroom that had some water damage done in there, so we haven't been using it. But let me know, remind me if you'd like a piece of paper. So you'll basically, and I'll show you the different examples that are in that classroom also on the wall, so you can kind of get an idea of what I'd like. So I'll probably just have you take a picture of it and send it to me. So this is just kind of a quick view of what a X-ray basically machine kind of looks like. If you're going down to radiology, a lot of the times we see patients in the ICU and even on the floor where they do a portable chest X-ray, where they actually bring a big portable unit and they're able to take the picture right there as the patient is sitting upright in the bed. Ideally, if you can get them out of the bed standing, they get a better picture, but just depending on the patient's condition. So basically what happens is the X-rays shoot out from that arm, so on the right side there, they shoot out like a beam of electromagnetic waves that radiate from that tube, which electrical currents then are passed, and then they're scattered onto the film. So the film in this case would be on his front part of his chest is where the actual film is, where the X-ray produces its image from. So we look at X-rays to help us detect what's going on with our patient. It's a diagnostic tool to figure out if there's something going wrong, like an illness, like a pneumonia or a tumor or some type of obstruction, or we also use it to determine if our therapy is appropriate, if medications that we've been giving, antibiotics to help clear up a pneumonia. Also, X-rays are done, chest X-rays are done after we put in an endotracheal tube to make sure it's indeed in the right position, at the right depth. If we put in different catheters, not so much us, but physicians, like a central line or a Swan-Ganz, to make sure that it is indeed in the right place. All these lines have like a radio-opaque line on them, or what do I want to say, a marking on them, so they're able to pick it up on X-ray to be able to confirm placement. We also want to make sure that we haven't punctured the lung with putting in certain lines, and then again looking at the progression of lung disease, and that could be an acute process like a pneumonia or a pneumothorax or pleural effusion, or it could be monitoring a chronic condition such as COPD. So X-rays absorb differently in different parts of our body. So when it goes through air, when X-rays shoot through air, it appears black on the X-ray itself. Okay, and that's called radiolucent. You're able to see through it. It goes like right through it. There's nothing stopping it. So on the film itself, it appears black. Now, if it's a denser tissue or a bone, it's going to be more radio-opaque. Okay, so radio-opaque means dense, or it's going to look white. And there's different densities in our body, not just the bone. Bone being the most dense, so it will be the most white or radio-opaque. Then water is not as dense. It's less white or fluid, basically, like a pulmonary effusion. It's kind of a lighter gray, fat is even less dense than the water, so that's kind of like a darker gray, and then air again being your least dense, and that would appear black on the x-ray. So there's different views. Ideally, as we saw in that one first little picture there, if they can go down to radiology and have the x-ray done, generally then the distance between the film and the x-ray source is about 6 feet, but a lot of times, we do see them do these portable x-rays, and then they're about 4 feet in distance. So the physician orders what type of view he wants depending on what they're looking for. A posterior anterior view would be the x-ray, like in that little drawing in the very first little picture there, where the x-ray goes from the back to the front. And so then the film basically is in front of the patient. Okay. And then an anterior AP view, anterior posterior view, the x-rays are going to go from the front to the back, and the film then is going to be in the back of the patient. So they do a lot of AP views when a patient's in bed, like in ICU. So after they've had an ET tube placed, x-ray will come up. We try to get the patient sitting up right in the bed, so just bringing the head of bed up so they're kind of sitting as much as they possibly can at a not quite a 90-degree angle, but and then the x-ray plate goes behind their back, and sometimes it's, we have to kind of help because we're often in the room right after they're intubating. We're checking the ventilator, making sure the tube's stabilized and whatnot, and then sometimes we're there to actually help, bring the patient a little bit forward, have them get the x-ray plate behind the patient. They have to lay on it, which of course is uncomfortable because it's like just this hard kind of metal plate. And then the radiology tech, gets his machine set up and does the x-ray. Those are the ones that, personally, respiratory sees quite a bit. In the ER, it looks maybe a little bit different. A lot of times, because the patients are more unstable, they'll just shoot the film with them laying supine, so they'll slide the film underneath their back. Certain beds, sometimes you can have a place where you can actually put the x-ray film in there. And then there's other special views, again, depending on what they're looking at. Lateral decubitus film is laying on your side, and that's generally used to help diagnose a pleural effusion. They usually have them lying on their side with their arms above their head, so they're checking for a pleural effusion. Apical lordic, that's kind of a weird little view, so they basically kind of have them leaning back against the machine, kind of at a 45-degree angle. So the apical lordic view is trying to view the apices, or the upper lobes of the lungs, and that might be used to help diagnose TB or cancer. An oblique is it's kind of different from the regular lateral image, where you turn approximately 5 degrees the abdomen towards the machine, so it's kind of like a lateral but a little bit more of a different angle. And then an expiratory view is one that they'll use to detect like a small pneumothoraces or small pneumothorax, and they can kind of compare the expiratory view to the inspiratory view to see if there is indeed a pneumothorax. So that is a question that advanced patient assessment got wrong on one of their MRE assignments. So you want an expiratory view to help you diagnose a pneumothorax. Remember that for third semester. So here is kind of another picture here of kind of that apical lordic view, where she's kind of leaning a little bit more towards the film than being on her back. So looking more at the right middle lobe or the apical area of the lungs. So here again is the PA. Okay, so the x-rays penetrate from the back of the patient to the film. So the film is actually on her front side, and that's fairly standard. So if you go have an x-ray done, that's generally how they'll have you stand. they don't want your arms out to the side so you're not creating any kind of shadow. Again, here's kind of another picture of it. The other thing that they like you to do is when they're doing the x-ray is to kind of take a deep breath and kind of hold it. So one of the advantages they have when we're bagging a patient, like manually ventilating them, you know, we can kind of assist them with that. You know, the x-ray tech might say, "Are you ready?" And then we'll give the bag a good squeeze and kind of hold it for a second while they shoot the film. And there's usually like a little beep after they've taken the picture, so you know when to stop holding the breath. Again, here is an AP, so that's where the x-rays are going to penetrate then through the front of the patient onto the film. So the film here would be underneath him on his backside, and you can see here the machine that's kind of up above near the ceiling there. That's the actual x-ray machine. So that's sometimes the way they might do it in the ER. I'm not exactly sure. It looks like they're possibly in radiology right there, where they just want it that way. Again, an AP is usually a portable, and a lot of times in the ICU, patients have a difficult breathing if we're laying them flat like that, so they're usually sitting upright, you know, close to a 45-degree angle, or 90-degree angle rather. Sorry, it's starting to lightning here. I'm hoping I don't have to shut everything down. You're going to get more magnification on the AP view, and the heart is going to appear larger. So one of the big challenges of getting any kind of x-ray, especially the portable ones where they're coming to see the patient, these patients are generally our sicker patients. They often have EKG leads on them, so the wires sometimes have to kind of be moved to the side a little bit, because that's going to create a possible image of looking like something other than, you know, lung tissue. You don't want to get it confused, especially if you're trying to look for different placement of other lines. We try to lift up the ventilator circuit a little bit to kind of get it out of the way, because there are sometimes temperature probes or heated wire circuits that might kind of cause like artifact or whatever. So extra imaging that you don't really want to necessarily see in your picture. So a lateral decubitus film. This is primarily used to evaluate for a pleural effusion. Okay, so your pleural fluid is going to be gravity dependent. So if you suspected a pleural effusion on your left lung, you're going to lay the patient on their left side, as in this picture. Now, if you expect a patient to have a pneumothorax, air is going to rise. So if they had a pneumo, you would put them in this position if you expected it to be on the right side, because the air is going to rise. So then you want that side up, the suspected side for the pneumo up, if it's a pneumothorax. If it's a pleural effusion, you're going to put the suspected side of the pleural effusion down, because the gravity, the fluid's going to kind of settle in the lower spot, or the lower area, I guess. Here's a picture here of a pleural effusion. Sorry, it's a little bit blurry, but you can kind of on the left side, so the patient's laying on their left side there, and that kind of area there, that's kind of marked A, that's kind of where the fluid is. Okay, so the whole lung itself is kind of the B part, the whole left lung, and then you can see about close to half of it, all that kind of haziness there is the fluid, and then the darker part would be the lung. So there's quite a bit of fluid there. Another view that they can do with x-rays that really isn't per se a chest x-ray, but a neck views, but it's kind of it's definitely respiratory related, is if you're evaluating a patient for croup, which is more common in children. But what happens with croup is their larynx area there gets swollen, and the kind of telltale sign is the steeple sign. So you can kind of see on the drawing on the left side there, where kind of the pink area there kind of comes to a point like a steeple, and then you can kind of make it out there on the x-ray on the right too. It's like a steeple of like a church. So that narrowing there of the upper airway caused by the inflammation. They often have a barky cough, they have a sore throat, they may have some difficulty swallowing. We generally will administer maybe a cool mist, possibly racemic epinephrine, and then they usually they put them on steroids. Epiglottitis, you need to get a lateral film to diagnose that. That would be more of a kind of an emergent situation. Epiglottitis can actually happen more to adults too. The epiglottis just gets very enlarged, and the pink arrow there is kind of showing to this kind of fat-like tissue, and they call it the thumb sign. So on some views it actually looks like a thumb, like this. If you look at your thumb sideways, they call it the thumb sign. So that's a way to diagnose epiglottitis. You do not want to mess with their airway. If you really truly feel that they are compromised and having a hard time breathing and cannot maintain an airway, they need an emergency trach. They will generally present really anxious, probably drooling because they can't even swallow. I've been fortunate enough that I have never seen an epiglottitis patient, which is kind of crazy, but I've seen croup, and I've seen angioedema where patients, and that's kind of a slower onset, but epiglottitis can definitely be an emergent situation. Okay, other types of evaluations, or other types of radiology that are not necessarily chest x-rays. CAT scans or CT scans, VQ scans, which we really don't do anymore, angiography, and fluoroscopy. So CT scan is computed tomography. It gives us like little slices, very fine detail, usually about 1 to 2 millimeter sections of slices. They can help. It can help detect and differentiate lung tumors, lymph nodes as small as 2 to 3 millimeters. They also use it to look at chronic interstitial lung disease. Can also be used for early detection of pneumonia, abscesses, cavities. They also can sometimes do it with contrast. So they inject contrast, which gives you a little bit more idea what's going on with the vessels. We do a lot of head CTs, looking at patients' heads. If they come in unresponsive, altered mental status, they have fallen, anything like that, they will take them for a CT to make sure that they haven't had a stroke or a bleed. So that's part of the stroke protocol too, is when they call a stroke alert, they get them in. They just kind of do a quick evaluation when they first come in. I mean, sometimes they don't even make it to a room. They'll just kind of do it like when they first come in the ER to assess for a stroke. Because if they're able to, if it's not caused by a bleed and it's a clot instead, they can go in there and do TPA and bust up that clot, so to minimize any damage from the brain. This is just kind of showing you the difference of looking at the same patient. Looks like they may have a mass or something going on here. So we have the chest x-ray on the left, and then on the right they could be doing a thoracentesis, or they could be doing a needle biopsy here with, you can see a syringe being inserted, so they can have a better idea exactly where they're going with under the CT view. Another type of those three different images there are kind of comparing a chest x-ray is on your left, obviously. Looks like they've got a defibrillator or something there. That little white thing is some type of mechanical device, most likely a defibrillator or a pacemaker even. On the right side is your CT scan, and then on your left, or I'm sorry, on your lower is the PET scan. And PET scans, I'm trying to see if I have notes. My slides are a little bit out of order from what I'm viewing here, because I redid this PowerPoint a while back and I'm trying to match up my notes. PET scans, I know they give to help detect cancer, and remembering from what I have in my other notes, and for some reason I can't find what I'm looking for right now, but PET scans, what they do is they have the patients fast. Oh, here it is. They have the patients fast, so they don't eat or drink anything, I think, for like about 6 hours, and then they give them glucose, uses a glucose analog attached to a positron emitter. So again, they fast for several hours. This glucose is injected with a radiopharmaceutical labeled sugar water, and the patient needs to remain supine, so they need to be laying down and they need to be perfectly quiet for about an hour. So what happens is that metabolically inactive tissues, so just laying there doing nothing, you're metabolically inactive, you're not going to use up that much sugar water, okay? So it's not going to be drawn to those areas. It'll usually look clear on the x-ray, but tumors and areas of infection have an increased rate of metabolic activity, and so that causes these hot spots. So the spots that are white there on that PET scan on the bottom view, those are the hot spots. They often will use CT and PET scans simultaneously to help and then kind of look at the images. They're kind of superimposed on each other to help diagnose. So PET scan is positive emission tomography. They do not use a PET scan to diagnose any type of brain tumors, because the brain uses too much energy and you wouldn't be able to differentiate those hot spots. Okay, MRI, that is definitely something that we visit a fair amount as respiratory therapists and taking our patients to CT and MRI. I'll talk a little bit more about it when hopefully we're back on campus again, just all the extra stuff, I guess, that goes along with it. It's very time consuming. When we take patients to CT, it's a fairly quick procedure. Generally the whole part of getting them down there and getting them over to the CT table takes longer than the scans do itself on a CT, because the technology is so advanced now that it just goes really quick. But a patient can be easily in MRI for about 45 minutes. But getting them into the MRI room is quite the ordeal, because we have to switch everything so that's not being attracted to the magnet. So it has to be MRI compatible. So you have to look for any metals. So they have to do a really complete assessment of the patient to make sure they don't have any metal implants. They have to change all their monitoring leads. They have to change their IVs, IV poles. We have to change them to a different ventilator. When we go into the MRI area ourselves, we have to make sure that we don't have any metal on us. So we have to, I usually would always wear a lab jacket, which had like my phone and whatever, scissors, whatever else tools that I had. So I'd always take that off, because that would definitely have things in it that would be attracted by that big huge magnet. So the CT scan is really pretty cool. It's very superior to your MRI is really super cool. It's definitely superior to CT. Of course, it costs a lot more money. It's helpful in evaluating for mediastinal and hilar masses. It helps differentiate lymph node enlargement from vessels to be able to see kind of really what we're seeing compared to what you might see in the CT. if they see something suspicious on a CT and they're not really sure what they're looking at, they'll send them to MRI. Definitely useful in looking at chest wall invasion of lung cancer. Another thing is they'll take patients to look at their brains with the MRI. So they actually use the PET scan, CT and PET scan more so for lung disease, but they can use it. They can use the MRI, but I know they use the MRI a lot for the brain and for the belly. Angiography. They look at this to see if there is a blood clot, if there's pulmonary embolism. So they can look at the X-ray of the arteries. This is where they would use contrast. They would have to do this through a pulmonary artery to use the contrast. So this is really not done so much anymore because it's too invasive. But we used to do it this way. Then in the lower picture there, they would inhale a gas that had radioisotopes in it, and that would be used to ventilation perfusion scan is basically what it is. But we haven't used that for a really long time. What they now use is CT angiography. There's no catheter needed for that. This definitely has replaced the pulmonary angiography and your VQ scan. Fluoroscopy is definitely something that you'll see. If you go in the cath lab, you'll see it. If you work in the ER, you'll most likely see it. It's kind of like a live X-ray. So when you are in a room and they're doing fluoral, you want to make sure that you're wearing your lead. Okay, so wear your lead apron and the little neck thing that protects your thyroid. So you can watch this cool little video clip. It's just basically showing this guy with fluoro, on live fluoro, swallowing a sword. It's pretty crazy. So another time that you'll see it is like when I was saying in the ER, they will use it to when you're resetting. So with the conscious sedation, I think I've talked to you guys about that, where you go in and you monitor the airway while they're resetting a bone or replacing a hip. They don't usually use fluoro for hips. They can generally kind of tell, the doctor can usually tell if they got it back in place. But if they're resetting like a broken bone, like an arm or a foot or ankle or something, they'll use the fluoro to kind of like see kind of live, like if it's in place. They'll also use it in the cath lab. They're doing it the whole entire procedure at the cath lab to make sure they're visualizing basically the coronary arteries. So when they put a stent in or when they put the dye in, you know, they have it, they're able to turn it on. It's generally with a foot pedal. The doctor will hit it when he wants it kind of to be able to see the image. All right, so when we look at the other thing with fluoro too is that they use it for bronchoscopies. They use it for the peripheral EBUS or the radial bronchoscopy. So you'll definitely, I'm sure, see fluoro being used. It's fairly popular. So when we're kind of looking at an X-ray, we have kind of like little steps, I guess. I mean, it's radiology, of course, that's their job too. They want to make sure the quality of the film is good. I mean, but it's just part of the process of kind of a systematic way. Checking to make sure it isn't overdeveloped or underdeveloped. That's obviously not our job, but it might be something that we might note. The beauty of the technology now of X-rays is that it used to be they would take the picture and then they'd have to take the film physically down to radiology, develop it, and then they'd send the X-ray up. Now everything is digital, and when they're doing an X-ray on those portable machines, they actually get a picture that comes up immediately on their machine where they can actually see it. You can see the X-ray, so it's pretty cool. So we don't have to like wait for several minutes to actually get the x-ray developed. Oop, there's some thunder. Before if we know if the ET tube's in the right place. So they have like a little screen that kind of pops up and shows the image. So that way they're able to check the quality of the film. You want to make sure the patient's in the right position, that they have a good inspiration, obviously the name that you did the x-ray on the right patient, and looking at seeing if all the lung fields are there. So there's kind of like an A, B, C, D approach. I have included on under the series of PowerPoints a link that I would like you to check out. It has a really good, if you really, because x-rays are, I mean, you can't just learn them like after one lecture. You really have to spend some time kind of studying. I just highly recommend it if I know you guys are busy, but there is a link called med-ed virginia.edu courses rad chest x-ray. There's like a little link I put in there, helpful resource for x-rays or whatever. And it's kind of like a little mini course. I think it's kind of cool, and it kind of goes through a little bit more, or focuses just on the chest x-ray. So we're looking at airways. The one thing that we're looking is to see if the trachea is deviated. You want the trachea to be midline, and sometimes it's not because there's a pneumothorax or something, or it could just be the turning of the patient or something, so they want to make sure that that's center and midline. You want to make sure there's a good inspiration, so you should be able to see the lungs expanding to about the 10th to 11th posterior rib. Make sure that there's good lung detail and there's an outline of the spinal column. There should be symmetry of the bones, meaning like the clavicles should, you know, look the side, your collarbone should look kind of similar to each side. There should be a cardiac silhouette, which is like kind of like a shadow of the heart. The heart size should be less than 50% of the chest diameter on PA films. So that means, and we'll talk about that on some of the different examples coming up. So when you're looking at the x-ray and you're looking at it like from kind of even from like left to right, the heart should not take up more than half of that area. It would be less than 60% on AP films. So if you have where your x-ray is showing up where the heart looks larger or the cloudiness looks larger, that could indicate cardiomegaly or CHF. Also, you're looking at the diaphragm. The right diaphragm sits slightly higher than the left due to the liver, and then your diaphragm is going to kind of lose its concave appearance and appear more flattened in COPD patients. Obviously, if they have an ET tube, we're looking to see if it's in the correct placement. We like it to be about 3 to 5 centimeters above the carina, so you have to know where to identify the carina on an x-ray. That's generally between T4 and T5, thoracic vertebrae. Fissures, that's evaluated for thickening, fluid, or change in position. You might be able to see those. A gastric bubble should be seen clearly. You should be able to see like a gastric bubble is generally on the left side, so it's just kind of like a little air kind of pocket, because generally when they're doing an x-ray, you'll get part of the gut too in the picture. And then the hilum is the area where the bronchi, the blood vessels, and the nerves enter and leave the lungs. So it's kind of in the middle part, your mediastinal area. So you're checking for the widening of the mediastinum. Can actually indicate aortic dissection. So the aorta is kind of starting to like blow basically, or it's dilated. Again, you're looking for tracheal deviation when you're evaluating that. You know, for pneumothorax or for a mass possibly. There's a lot of information on this one again. So again, I'm just kind of seeing, so your cardiac shadow is always going to be on the left side. So when you're looking at x-rays, you have to kind of get used to, usually they have one of the sides marked with an L or an R, but whenever you're looking, so like I'm looking at my computer screen right now, the right side, yeah, I'm just making sure I explain this right, the right side of my computer screen, you know, when I put my right hand up, is really the left side of the patient facing you. So just you kind of have to get used to flipping that view around. This is just kind of talking about looking at to see if it's overexposed or not. It's kind of some of the stuff that I already talked about. Inspiratory, you want it to be 10 posterior ribs on the PA film. Here's a nice x-ray here. You can see, so again, looking at this, you can see that on the left part of the screen, which is the patient's right side, their hemidiaphragm, so the patient's right hemidiaphragm, whereas you're viewing it on the left, sits a little bit higher, just slightly higher. You can see the costophrenic angles here at the very bottom. There should be pointy at the very bottom of the picture here. The heart border here is not greater than 1/2, so you're looking at the white kind of part there where the heart kind of comes out here on the patient's left side again. All this other little haziness here is vessels in the area. You can see the spinous processes on the x-ray, so this is probably a PA film, so you're looking at the picture from the back. You can see the clavicles, you can kind of see the scapulas here on both sides. Here's another picture kind of with different labels. The bronchial bifurcation, so that's the carina. So at that base of that, pretty much if you line up that line right with that area there is where the carina is. So when the tip of an ET tube, which has a radio opaque mark on it so you can see it, you should have that ET tube somewhere below the clavicles but above the carina. So about 3 to 5 centimeters above the carina, but definitely below the clavicle. So this is give you some different landmarks here. Kind of see the little gastric air bubble on the left side, the liver, which is pushing up the diaphragm on that right side. And if you look at that other resource I gave you, that'll go over some things for you too. So again, heart should be on the left, gastric bubble should be on the left. Here's another one. I had to enlarge this picture. It's not as clear as far as being able to read it as well. But you've got your costophrenic angles, your diaphragm. You can kind of see the oblique fissure. Kind of outlines the heart for you. You can see the superior vena cava. Okay, so now you're ready. Well, we're just kind of taking a peek here, looking at some of the things that we've already talked about. So we're looking at the diaphragm. There's abnormal elevation, especially on that right side, and the margins should be sharp, and they're kind of blunted here a little bit. You don't see them quite as well. Oh, now it's starting to rain really good. So again, you're looking at the heart. You don't want it to take up greater than 1/2 of the thoracic diameter. Remembering that AP views make the heart appear larger. So anterior, posterior views, so taking the x-ray from the machine, the beams are coming from the front to the back, where the film's on the back. Here's just another view of an x-ray kind of showing the cardiac silhouette, where you're able to kind of sort of identify some of the different vessels here. You're not going to really be responsible for doing that. I mean, you just want to make sure your trachea is definitely midline. I can kind of see the carina. I don't think you can see my arrow while I'm doing this, but Actually, you know what? I wonder if so here's the carina. Oh, darn it. I was trying to do the little marker thing like I used to do in math. Okay, this particular film, I hope you see something wrong with it. We definitely have a enlarged cardiac border. Okay, so that whole white area is definitely greater than 1/2. Okay, so this is, and then all the white fluffiness, they kind of call it, is the pulmonary vascular congestion, kind of around the heart area in the middle part of the x-ray. Your margin should be sharp, so this is what they're talking about on those costophrenic angles. I'm curious how come this, oh, here we go. So here's your costophrenic angles right here. Gosh darn it, I wish I could have. Oh, here's kind of like your carina, right about here. You'll get kind of used to it after you've seen more x-rays. Again, here we've lost the cardiac border, showing some consolidation here on the right side, this whole fuzzy part. So you're looking for infiltrates, increased interstitial markings, masses, absence of normal margins, aerobronchiograms, we'll talk about that, increased vascularity, but keep in mind, I mean, the physicians are also looking at these x-rays, and there's radiologists who've gone to school for, I mean, this is their thing, but it's helpful for us to recognize some really gross abnormalities kind of, and be able to recognize the landmarks and be able to tell where ET tube is and where the carina is, and recognize a pneumothorax or pneumothorax and a pleural effusion and some of the other things that I've talked about, like the increased cardiac, oops, I think I'm going to get a lot of lightning, a lot of thunder. Okay, ooh, jeez Louise, made me jump. Okay, oh, perfect, aerobronchiograms. So aerobronchiograms, they are basically kind of an area where you're seeing kind of like a contrast between the air, so it's on those black arrows there is the aerobronchiograms. The air column becomes visible by the surrounding alveoli because the alveoli are filled with air, but the bronchus itself, the bronchi, are thickened. Okay, so let me take a look here for 1 second. So you're kind of looking at the contrast, like with the pneumonia, you're basically looking at the contrast. The alveoli contain, and I think I might have misspoke, the bronchi are filled with air, okay, but the alveoli contain pus and exudate like in a pneumonia, but the bronchi are still patent. So you're seeing that contrast there with those black arrows of the black line being the air in the bronchi, and then the white part kind of surrounding it is the thickening of the alveolar wall from the inflammation. So it can be, generally you don't see the distinguishing part of that after about the 4th order of the tracheobronchial tree. But then when you have a pneumonia, not always, but sometimes you can see these aerobronchiograms. Atelectasis, basically your lung has collapsed down. It can be compressive or obstructive. So compressive would be from a pneumothorax. Obstructive could be like a blockage in the airway caused by a mucus plug possibly, or a tumor. So here is a picture of a pneumothorax. Definitely on the left side. So here you can see on this x-ray that there's actually a L, so that's telling us that that's the left side, so that's always helpful. But you can see how the darkened area here, let me see if I can get my little pen again. So here's kind of like the border. This is kind of like your border. So all this black area is collapsed. It's all collapsed lung. Okay. I should erase that. So there's your border right there. And then again, the dark area would be the pneumothorax itself, where it's collapsed. A tension pneumothorax can cause atelectasis. That's generally where you've gotten positive pressure, and this can be a side effect from positive pressure ventilation, and so you'll have a mediastinal shift. So the X-ray, so the oh jeez Louise, made me jump again. Okay, so the pneumothorax here, so this is a left-sided tension pneumothorax. You can see how the pressure inside the left hemothorax has actually depressed the diaphragm there on that left side, so it doesn't have that angle. It's kind of flattened out, and it's basically has also forced the heart to kind of shift over more to the right side. So a chest tube has to be placed immediately in these patients because they can actually decompensate really fast. All that pressure can actually decrease the venous return and kind of squish the heart and squish those large vessels, and their blood pressure can drop out pretty fast. So this is considered an emergent situation. You want to get a chest tube in as soon as possible. Hyperinflation here, this is a good picture. You can definitely see the flattened diaphragm. So we'll see these in our COPD patients. Large airspace, meaning that the space in between the ribs is wider. Generally the ribs aren't spread out quite that far, they're a little bit closer. And then that increased AP diameter, which is a little bit hard to see on this film, but you can see it on the lateral film. So just making sure I'm not forgetting anything here. Here's where you're going to kind of see that increased AP diameter. So the severity of the emphysema and pulmonary hyperexpansion in the patient with COPD is often predicted by the size of the retrosternal airspace. So that retrosternal airspace is kind of like here by A, or by the double A. There's kind of a big space of air between here and the sternum itself. So the larger it is, the more severe the COPD or the emphysema is. And make sure you look at chapter 10 in Wilkins. That's your good resource for this lecture too, is to look back at chapter 10 in Wilkins. Interstitial lung disease. That's basically something has activated the patient's immune system and their lung. It's become scar and fibrous. They develop scars, so they get really stiff. It takes months to years for it to progress. It also can result in a combination of cardiac and respiratory failure. So sarcoidosis, some of the characteristics are large hilar and paratracheal lymph nodes. Asbestosis is calcified pleural or diaphragmatic nodules. End-stage pulmonary fibrosis, you'll see honeycomb cavities, and you'll see that kind of more on actually on a CT scan. And then bronchiectasis, you'll have those large air bronchiograms with thick walls. So you'll see a definite definition of the bronchi and the surrounding tissue. So also look at your textbook. There's some examples of air bronchiograms. They have several pictures of x-rays on that in your book. This particular slide here is showing interstitial lung disease. You have smaller lung volumes. There's coarse linear and cystic lucencies that represent the pulmonary fibrosis. So it's kind of white, patchy, kind of like cotton candy, sort of. If you were to take cotton candy and kind of spin it out or stretch it out a little bit. That's kind of what it resembles, or like some kind of stuffing or a pillow. Here is the CT showing honeycombing on end stage. Just going to see which. So honeycombing being all this stuff in here. It looks like a honeycomb. Have some over on this side too. More so it looks like on that left side. So, and it depends where they've taken the picture. So this is CT, so it's a slice. So it kind of just changes sizes as they progress, through the machine. So here's a list of interstitial lung diseases. You can see there's various causes, occupational, physical agents, unknown causes. So if it's unknown, they're going to call it idiopathic. So there's all sorts of different idiopathic disease processes. It's basically saying they don't know the cause. So idiopathic interstitial lung disease. Different infections can cause lung disease. Histoplasmosis, coccidiomycosis. I mean, there's several here listed. And you guys know it's advanced patient assessment. They have to pick a disease process, and then they have to build a clinical simulation. Something you'll get to look forward to. All right, congestive heart failure. So congestive heart failure, you're going to see an enlarged heart, these little curly B lines. So just know that curly B lines have to do with CHF. Okay, that'll probably be a test question. How can you diagnose CHF on an X-ray? Or what do curly B lines mean? Congestive heart failure. They're little horizontal lines. They're kind of showing a consolidation vascular markings. And there's actually a good example on that website that I told you about from the University of Virginia. So basically there's redistribution of the pulmonary vasculature, there's engorgement of the upper lobe vessels, the fluid collection is in the dependent portion of the lungs, so gravity dependent, and again you're going to see that big heart size. So here is a picture of your CHF. You can see it's greater than 50%. The curly B lines look like they're over here on the definitely on the right side here on the top. I was trying to find a little more information on this film, but I can't. This lecture was, for the most part, I think, done before I kind of joined PIMA. But I'm looking. So the heart's slightly enlarged. It isn't super big, but I'm quite certain those curly B lines there are on that right upper lobe here with that one arrow. All right, a pleural effusion generally is greater than 100 mils of fluid. There's usually about 50 mils anyway in the pleural fluid, which is normal. Again, you need to confirm that with a lateral decubitus X-ray. So a small volume pleural effusion will blunt that costophrenic angle. So those little points on the bottom there by the diaphragm will be blunted. You won't see it as well. A small meniscus sign just basically means kind of like a slice of like a moon, like a real like when a moon is just like a sliver, basically. That's the meniscus sign. You could have a partially obscured and elevated hemodiaphragm compared to a large pleural effusion. We've seen one on the previous films where you have nearly a complete, they'll call it a whiteout, completely obscures the hemodiaphragm. And again, the best way to diagnose it is by a lateral decubitus film. So you can kind of see the difference here. You have fluid obviously on the left side, totally blocking. You don't have any costophrenic angle here. And kind of like that little dip there by the red arrow, kind of like that's your like little kind of meniscus sign. Here's a huge pleural effusion where you have a whiteout on the left lung. So they would definitely do a lateral film to see if that is indeed a pleural effusion. Here is one on the lateral film where someone is laying on their, looks like they're laying on their left side. Kind of hard to tell for sure. I think this one is actually in your textbook. Let me look really quick. So this is actually on page 209 in your textbook. You'll see this picture here, and I'm reading through it and I don't really see, it's not really saying what side, but as I'm looking at it again, I can see now there's like a little ID plate, and usually that's it's on the top part of the film here in the corner. That's usually on the left side. So it looks like he's lying on the right side because the heart does look like it's taking up more space here on the left, on the top part of the lung. So this is a right-sided pleural effusion, but you can basically see how the fluid level here is kind of layering out, and again, it being gravity dependent. And then this is our last slide, and this is basically showing a consolidation. So we have some really thick mucus plugging going on. They could possibly do a bronchoscopy on this patient to see if they could get out a bunch of secretions and kind of open that lung back up. Okay, definitely take a look at that extra resource, and I will see some of you tomorrow, which is Thursday, but this lecture is for Thursday, but I will see you also on Monday. Thanks so much.